Respected chairpersons and learned audience, Assalamu alaikum and good morning. I'm Dr. Mohammad Walidur Rahman, welcoming you all to my case presentation. Today I'm going to talk on a case in which, in case of delayed diagnosis, the death toll rises about 1 to 2% in every hour for the first 48 hours. And it's been frequently misdiagnosed. High index of clinical suspicion, along with bedside transthoracic echocardiography, can save the patient from the disastrous consequences. So a 59-year-old hypertensive lady got admitted with the central severe chest pain for 1 day. On admission, her vitals were stable, and her ECG showed sinus bradycardia. The admitting physician labeled her as a case of acute coronary syndrome and treated accordingly. But her chest pain didn't subside, and on examination, her pulse was 66 beat per minute, regular, and all the peripheral pulses were present. Blood pressure was 100 by 70 millimeter of mercury, and there was no significant differences of blood pressure in between the arms. First heart sound was normal. Aortic component of the second heart sound was a bit soft, and there was a grade 3 by 6 early diastolic murmur in the left sternal area. Given the physical findings, we immediately shifted the patient to the echocardiography room. Here you can see that the 2D M mode echocardiography at the pastern long axis view, showing that the root of the aorta is a bit dilated. The LV global systolic function was good, but LV IDD was borderline dilated. So this is the color flow imaging at pastern long axis view, showing severe eccentric air jet. Here you can see that the air jet occupies more than 65% of the LVOT word. And here it is the modified pastern long axis view. Here you can see the beautiful dissecting flap, and along with that, the root of the aorta and ascending aorta was also dilated. Pastern short axis view, here if you look at this, you can see that it was a morphologically normal tricuspid aortic valve. And if you look carefully at the LCC, you will be able to find a dissecting flap. This is the apical four-chamber view, showing the wall motion abnormality of the inferior septum, and anterolateral wall was good. And in case of aortic dissections, in some cases, the right coronary artery gets involved, and in that cases, inferior septum wall, and particularly the inferior wall, there may be presence of hypokinesia. This is the continuous wave Doppler in the apical five-chamber view, showing dense spectral tracing of aortic regurgitation jet with pressure half time of just above 200 milliseconds. This is the apical three-chamber view, showing beautiful dissection flap and also the presence of severe aortic regurgitation. This is the suprasternal notch view. Here you can see that the dissecting flap. And you can also see the neck vessels, that is the brachiocephalic artery, left common carotid, and the left subclavian. And obvious involvement of the left brachiocephalic artery could not be made common in this view. And the descending aorta, so far we could be examined in the suprasternal notch view, was not affected. So we made the diagnosis of acute aortic dissection stand for type A with severe aortic regurgitation, and after modifying her medical management, we immediately referred the patient to the thoracic surgery unit. So why we are talking about this? The thing I have already mentioned, that the aortic dissection has got high 30 days mortality of about 40%, and it is frequently misdiagnosed. It was shown that in 16% of the cases, it was not even included in the provisional diagnosis of chest pain. High index of clinical suspicion and transthoracic echocardiography can play an important role here. So in case of suspected aortic dissection, we should go for immediate transthoracic echocardiography. If there is presence of high-risk features or there is confirmed dissection, we should transfer the patient to the cardiothoracic unit where transesophageal echocardiography should be done. And if the clinical suspicion is high despite of absence of high-risk features, we should go for transesophageal echocardiography, CT scan, or MRI. So to conclude, transthoracic echocardiography has got excellent sensitivity of about 78 to 100% for detection of type A dissection, and type A dissection is the most dangerous type of dissection which will give you no time. And it is useful in establishing or refuting the differential diagnosis like acute myocardial infarction, pericarditis, and pulmonary embolism. It can also identify the high-risk features like aortic root dilatation, aortic regurgitation, pericardial effusion, or wall motion abnormality. But if transthoracic echocardiography doesn't show you the evidence of the aortic dissection, you should go for transesophageal echocardiography or CT scan or MRI in clinically suspicious cases. Thank you very much. Thank you for your patience hearing.